Hello, everybody. My name is Marc Laporta. I'm a psychiatrist in Montreal and director of the Montreal WHO Collaborating Center. We've met before, and we were supposed to meet a few weeks ago when it was scheduled to have the psychosis lecture, but I wasn't able to connect because of technical problems. So I'm going to do the session now. I hope that it's still useful to you, even though we're a couple of weeks late. So part of the base course of the VCmhGAP intervention guide and of this course, obviously, is going to be psychosis. Psychosis is the most characteristic of the disorders that we see in psychiatry, and you're going to see it undoubtedly as well. Now, as you see on this first slide, we're not going to be taking the time that the slides say, because as usual, you're going to be doing some of the quizzes, role plays, and discussion groups independently of this presentation. So I'm only going to do the presentation of the material, and the work around this material you're going to be doing separately. So the 40 minutes for introduction, forget it. And then we're going to have the objectives, and then always the same key actions about communication, about assessing, about management, linking with other services, and follow-up, okay? Always the same format. So as an introduction, I'd like you to just take a second to describe maybe in your own minds a person with psychosis. What distinguishes them? How are such people treated by society? This is really an unusual question, but it's really trying to get at how these people are perceived and at the issue of stigma, which is huge in psychosis. I'm sure that's the case in your countries as well as it is in Canada. What do you know about psychosis? It's important for you to ascertain so that you'll compare your notes with what we talk about and whether you've ever met anyone with psychosis and what the symptoms were, so that you have in your mind an image that you can stick the information to. It's always a useful way for information to become alive, real, and relevant. The psychosis really is about loss of contact with reality. And that happens, usually we think of it through hallucinations or delusions. So hearing voices, or hearing, sometimes it's not only voices, you can be seeing things. So it's any sensory modality. The most common is auditory, but it can be visual, it can be olfactory. Obviously, when it is not auditory, one has to rule out other issues going on as well, but we'll get into that later. And then false beliefs, meaning delusions. So people really believe something that either can be proven wrong and isn't in keeping with the person's cultural background, isn't shared by other people around them, and is implausible. So one of the difficulties with psychosis, as in with other disorders in psychiatry as well, is insight. The person may not be aware of the psychosis. This is always something which is challenging in order to establish a therapeutic relationship. What is acute psychosis? It's psychosis within the last 3 months, or worsening in the last 3 months. To me, 3 months is pretty long, frankly, but still it's considered acute by definition. What's the natural history? Typically, psychosis that is part of schizophrenia begins early, somewhere in late teen years, early adult years. Not all psychosis comes at that time, but psychosis related to schizophrenia certainly is. Usually there are 3 possible courses. The person recovers completely, or they recover, completely and long term. Or the person recovers but then has relapses, so it can be a relapsing course. Or more rarely, the symptoms continue on the long term for a long time. we wanted to take a moment in the presentation for you to consider locally what the realities are in order for you to adapt this slide kit to your own realities. So what do people believe the causes of psychosis are? By knowing what people believe, you'll be able to adapt your psychoeducation and your explanations to the patient and to the family, to where people are coming from. Okay, how are these people treated in the community? Getting at what we thought of before, you're going to want to tap into this, whatever is positive and therapeutic. Where can people seek help? What are the resources available? So you can take a moment to think about this. You can pause. The other slide that is about adapting the kit to your local reality is, how do you call psychosis? How do people in your country or even in your locality call psychosis? So, you know, obviously many terms that we hear are rather negative and viewed with a critical kind of approach, where people are cursed or they're stupid or they're dangerous. It's important to know that also, because you're going to want to help people understand that you're dealing with an illness that can be helped. Psychoeducation is going to be based on helping people not take the illness personally, but see it as something which can be helped with your intervention. So you want to seek culturally appropriate language. Facts about psychosis. Psychosis occurs frequently, about a person every 1 to 200 people. So it's not that infrequent. Actually, the literature points to the fact that it may be more frequent than that, but we don't necessarily hear about it. There may be transient forms. Certainly, psychosis can occur transiently when people are abusing drugs or even alcohol. The fact about psychosis is that the effect of it is dramatic on the patient, on the family, on everyone else. But as a clinician, I'm very sensitive to the impact on individuals and the fear that it brings to them. When people have psychosis, often their relationships with people and their ability to hold a job is heavily affected. They often get discriminated against. They might be seen as criminals. They may be confined. And there are human rights violations based on a misunderstanding of what this is. The other issue is the burden that it represents if people are not cared for adequately by the healthcare system. You're going to have to excuse me. I'm going to be clearing my throat a lot because I have some bronchitis these days. Psychosis can be managed outside hospitals, so that's important for you to know. The care can be offered in non-specialized healthcare settings like yours. So much of the medical treatment can be simple, so it's very often very effective. You're much more accessible, you're much less stigmatized than it would be for people to access specialist care. By the time people who are suffering from psychosis get to specialist care, they will have waited too long. The psychosis will be profound. They will have cut off from their usual lifestyles. So you want to avoid that by trying to help them earlier. Okay, what are the learning objectives? To be able to assess a person with psychosis, to be able to assess other underlying conditions or concurrent conditions, but also have a differential diagnosis. Thirdly, to be able to manage psychosis, certainly the first line aspects, and then to know how to interact with your resources, when, how, where to refer, and how to follow up. So let's start with establishing communication and building trust. As we mentioned before, someone who's coming in out of touch with reality will be suffering from disorganized thinking, often unclear thinking. So it may not always be easy for them to communicate with you or to establish a good relationship. The person might be sharing with you beliefs that seem strange, far-fetched, unbelievable to you. You're going to have an attitude where you're listening carefully, and you could question these things, but in a respectful manner, understanding that this is the worldview that the person has imposed upon them by the psychosis. That person might refuse to speak. For example, if someone has the conviction that you're spying on them, or that you're part of some organization that is spying on them or wanting to spite them, or if they're paranoid and they think you might want to harm them, they may well refuse to speak to you. I do not necessarily confront someone on that, but try to round the corners, explain why I'm there, go over our role, and try to establish the contact. The person might avoid eye contact for all the reasons mentioned above. If they have no insight, they may not feel they need medical care. Even if they have insight, they may think that have another explanation. And if they think it's a curse, for example, they may not understand that medical care is relevant. It's not rare, though, that the person who comes with a complaint is a family member. Okay, so you want to establish communication. You want to treat them with respect, dignity. You want to try to understand their perspective. Well, that doesn't mean agreeing, but it means understanding their perspective. You're going to be introducing your questions in a respectful way. Often I frame it and I say, look, I really want to understand, and I'm going to ask you this question because I want to try to put together what has been happening to you and why you're here. You don't want to rush things. That may take more than one session to build trust, and that's a very important point. You don't want to force the person to be in a position of discomfort that will result in their not returning. You want them to come back, and if it takes 2 sessions for them to build trust, so be it. You don't want to challenge the false beliefs or mock the person, right? So I've mentioned before, you want to understand it, and at worst, if they say, "Don't you believe me, doc?" you can say, "I don't see that," or "I don't hear it, but I really can understand that you do, and I want to understand. I want to help you with that." Ask how the person's life has been affected. So that's important to understand the consequences and the depth of the psychosis. And you're going to be advocating on their behalf. So when they know that you're on their side, you're not working against them. That'll be helpful. How do you conduct the assessments? The process of assessment, this is from the intervention guide. You're going to recognize it if you turn your intervention guide and open it to this page. The presentation does suggest a priority condition, doesn't it? So you go on to the relevant module, you conduct the assessment according to the module, and so on the master chart, psychosis, there's a quick description of the common and main symptoms. I'm going to let you read through that. You can halt the slides for a minute and read those. As you see, though, it does include also mania. So although we talked about bipolar disorder, manic symptoms, not hypomanic, but manic symptoms are psychotic as well. As you'll see also, the second to last point there, neglecting the usual responsibilities related to work, etc., often represents psychosis. It's not psychosis itself. It is not a hallucination, but it's something that happens as a consequence. So as you go through your decision trees, this is page 18 of the VCmhGAP intervention guide. I hope you've received, or at least you have access to online. You will look through the symptoms, and if multiple symptoms are there, you want to know if it's a first episode or a relapse or a worsening. And then if it is acute, we have a decision tree in the third column on the right as to ways of intervening. We're going to talk about that a little later. You're going to want to, in your differential diagnosis, you want to rule out psychotic symptoms due to addiction, but also delirium, Other medical conditions. So when there's a very acute, or mania, but when there are very acute conditions, you always want to rule out a medical condition. By the way, you know, this doesn't necessarily occur in someone who's 15 to 25. I've seen first episode of psychosis occurring in people who are 45 or 55 or 65. But the pattern becomes very important in order to be inclusive on your differential diagnosis. I'm going down now on the left column to number 2. Does the person have chronic psychosis? If they've been around for more than 3 months, and you have a different set of recommendations in your right-hand column that we'll talk about later. Okay, so be it for the use of the MHGAP intervention guide. If we go on, number 3, is the person having an acute manic episode? If yes, then you're going to want to go to the bipolar module. So we have here, obviously, manic episodes can be classified as psychotic or manic, as mentioned before. You're more likely to recover completely in bipolar disorder than in schizophrenia, but that rule applies in a very variable way. I wouldn't generalize that necessarily. Then you want to look for concurrent conditions, like we said before, and always important is suicide and self-harm. But then if there are other concurrent conditions where you can do something to help, then you're going to want to manage both those conditions as mentioned on the right-hand side. If it's someone, a woman of childbearing age, you're going to want them to be seen by a maternal health specialist. And there are risks of adverse consequences to the mother and baby with psychosis. You know, there are some with some treatments as well, but that's another issue that we will probably be dealing with the specialist if you get to that point. We'll talk about it more later. So here, as you see in the box on the right-hand side, we're asking you to avoid routine use or the depot antipsychotics. Okay, so assessing for psychosis, you want to identify the symptoms, ask about previous current episodes, and rule out other causes. The symptoms in the MHGAP, incoherent or irrelevant speech. It may be fragmented, disorganized, brief replies, what we call often loose associations, where people may go answer questions in a way that seems quite irrelevant. It only makes sense in their psychotic world. Delusions and hallucinations are key symptoms that we talked about already. So false delusions being a false belief, but the person is very convinced about it. We have examples there. People in disguise, or the royal family, or hallucinations are misperceptions. There can be noises going on that they misperceive much more, and that can also be considered. And if they just hear inchoate noises that seem to be related to real things, then I would really question more carefully and observe longer to see whether this is a hallucination. Just quickly, as mentioned before, most commonly auditory or visual. Often one gets withdrawal, agitation, disorganized behavior. People are very confused and their contact with the world is broken. So these are symptoms that are consequences of that. The social withdrawal and neglect are often seen when the psychosis has lasted longer. Decreased interactions, self-neglect, loss of interest, and not like depression, but it's more an amotivation very often. People just are not interested and don't necessarily regret it as you would in depression. And day-to-day activities are difficult to carry out because of disorganization. Again, often not with that much torment, but simply as a fact that they will be able to describe So here you have examples of how to ask about hallucinations and delusions. And I would strongly encourage you to listen here to the video that you have available through a link on the virtual campus site on psychosis assessment. You have two different videos. One is on the assessment and the other is on management. I would strongly recommend that you look at the assessment one now. It's a few minutes long, but well worth it. Do you hear voices? There's three things. This could be part also of your role play, so I will not stay very long on this slide. Do you believe that someone is planning to harm you, etc.? I will let you work on this with your tutors. What do you need to know about the current previous episodes or previous episodes? You have to ask the family as well. When did this begin? Are the symptoms worsened? Is it stable? If a person, consumed amphetamines, they would not be expected to have psychosis that would last for a week or 2 weeks. You want to know whether prior episodes occurred, because if this is a relapse, we may be dealing with it differently. And then it's useful to know how people were treated in the past and what worked, what didn't. If they were adherent or not. And if they were not, why that was, so that you can avoid the same pitfalls. We mentioned before that there's a differential diagnosis. This highlights that once again. Substance abuse or withdrawal and acute medical conditions. Some of you will be in areas where malaria can be a contributor to this or a cause of this. Infection. Certainly, I've seen people even just with urinary tract infections in other elderly people, for example, that develop psychosis that looks delirious, slightly delirious. Sepsis, obviously, or severe fever, head injury. So you want to rule out symptoms due to substance abuse. We're going into this one more time. We talked about it. So for that, if you see that there is something related to substances, we strongly recommend that you look to the relevant MHGAP intervention guide modules on these issues. In terms of delirium, you're looking for more confusion, something that's more acute. There's clouded thinking, clouded awareness, disturbance in orientation, sometimes, not necessarily, but sometimes. And it can include symptoms similar to psychosis. Many of you know this probably better than I do. We see it mostly when we're working in the emergency room. Now, the management of delirium, as you know, you want to identify an underlying cause and manage it. Dehydration is important. You want to make sure that if they're acute, you don't want them to be pulling IV lines out and banging into things in your emergency room, for example. But they have to be comfortable nevertheless. If you make them uncomfortable or act in an abrupt or aggressive or confronting way, you're likely to make them even more delirious, more confused and afraid. So you presumably know the rules to that, but it's always worth repeating them. You may need to refer at that point if there isn't something medical that you can do yourself. Are they having a manic episode? Okay, so just to review quickly, that's an acute episode lasting for at least 1 week, where the mood is elated or irritable often. The affect is often irritable, and this is something that's quite prominent. They may be charming to you, but family may tell you that they're very irritable, or they may be irritable in the emergency room. Usually, excessive energy, usually excessive activity and talking. There's risk-taking behavior that's out of keeping with their usual, that we can call recklessness or loss of control. We ask often about their driving, their money, their parental capabilities, and their ability to take care of their money. These are risks that we're always quite concerned about, and that often needs to be, something needs to be done acutely. Okay, so this is a drastic change. Usually manic episodes occur quickly, and so that's characteristic. That's good to keep in mind. The implications for you is that if it's very acute and severe, you will want to refer. You may have to hold that person in the emergency room until you can be sure that the risk behavior is no longer present. But you always refer or consult or refer to a specialist. I hope that that's relevant in your setting. Now, always keep in mind the risk of suicide. Psychosis carries with it a high risk of suicide, and it may be for reasons that you would not have predicted. For example, someone may think that devils are after them, or ghosts are coming through the walls, or the FBI has found them when they hear a siren going outside of their window from an ambulance. That may be enough in their psychotic world to justify their wanting to hurt themselves. So obviously, you still want to look for current thoughts, current plan, which they may or may not tell you. I hope that they will, or you can corroborate with them. When we know about past history, in particular, if there was psychosis that they got that way, if they became agitated, violent, distressed, uncommunicative. Okay, now we're going to talk about management. How are we doing here? Have time? I think we're hopefully doing okay. You want to share the results of your assessment of this person with that person and the family in a way which is going to be sensitive and palatable to people, so that you don't lose whatever tenuous therapeutic relationship may be there because of the psychosis. Now, psychoeducation is a very important aspect, and you've heard about it in every other module. I think that here it's particularly important for people to understand that there's a medical condition and they're not to blame. You're on the same side as them, trying to understand the psychosis and manage it. They may want to make sense of it, which is fine. Making sense of it doesn't mean that it's them or that they are to blame. Understanding, for example, that you're delusional can be very helpful, because then instead of really thinking that the FBI is after you, if you're in the States, or that the police is after you, or that Martians are after you, you may understand that that is a delusion and recognize it that way and not act on that, or act on hallucinations, for example, that may be commanding you to harm yourself or to harm other people. So understanding, helping people gain insight is extremely useful. It may take some time, and it may be something that you have to repeat constantly on an ongoing basis. It's often the case for myself. By the way, I direct an early interventions center for psychosis, and these are issues that we work on constantly. We want to encourage psychosocial support for the person and for their carers, because that is one way to help them keep contact with reality, to help them learn that whatever fears they have are not justifiable in the relationships that are being put forward to help them. Then you want to explain antipsychotic medications, and we're going to talk more about those later. And you want to make sure that everyone accepts the treatment plan, because the rate of poor adherence to treatment can be very high, and you want to make sure that you're treating this person. Partial treatment prolongs suffering. Full treatment makes it possible more quickly to reduce doses and to get people back to their normal life. So doing a good full treatment early is a goal. Okay, what is psychoeducation? Page 20 of your MHGAP intervention guide. What are the advantages of conveying the messages? This I'm going to let you do again with your tutors. You can take a moment now also to go to your page 20 and read the issues related to psychoeducation. Which of the messages are hard to convey? How can you convey them better? Are there any that you don't agree with? Why? Talk about it with your tutors. So you want to break the sense of isolation. You want to let them know that you're here to help them, that they can recover, and that you can reduce the suffering. It's important that medication, they know that medication is there to help them, and I often tell them that the medications are not a one-way street. We can try, we can start slow, start low, and it's something which we're going to test the tolerance of. And if they can't tolerate it, we may change medication, or we may change the dose. So that's the kind of thing that engages the person in the process of intervention. With the family, we want to help them understand that criticism and hostility usually are signs that you're taking the person's psychotic behavior at face value, instead of understanding that they may be strange or insulting or bizarre because of an illness. Once you understand that it's because of an illness, you don't criticize the person anymore. You're less hostile towards them because you understand that they are subjected to an illness process, and you indirectly are subjected to it. I mean, the parents, the family, are also subjected to it. And so are you, as a matter of fact, as a physician. They want to know also that it can be helped. They have a role in reminding the patient of the importance of taking medications and of following treatment. And they are going to be welcomed to let you, to contribute to letting you know how things are going. Remind them that they want to be advocates also for that person and their family who's suffering from psychosis. Okay, so are antipsychotics better started early or late? What is your answer? Early. Okay, that might be on your quiz, actually. We knew that because of what we just mentioned before. The later, usually, the longer you wait, the worse the symptoms get. Is it better to start with a low dose or a high dose? I gave you the answer before. Almost always with a low dose, unless someone is already well known to you and is relapsing because they just stopped the dose that you knew to be therapeutic, at which point you may want to restart that dose where they were at, what helped with what helped. Starting low, though, does usually reduce the likelihood of side effects that we will talk about later, and improves your therapeutic relationship. However, you don't want to go so slow that symptoms remain for too long. So we're going to talk here about the two main medications that the WHO includes on their essential medications list. You may have others in your countries that you will want to talk about as a group, maybe with your tutors, but they're not covered specifically here in the slide kit. So we talk about two very, first generation medications, haloperidol and clopramazine. Haloperidol being a high potency dopamine blocker, and clopramazine being a low potency blocker. So both usually the starting dose is very low. And the typical effective dose for haloperidol is 3 to 20. In fact, I almost never go over 10 milligrams because, in vitro, you get very good dopamine 2 receptors blockade with 10 milligrams. So, you know, sometimes you do need more. Sometimes there, in some cases, rare cases, there may be some tolerance, very rare, where you need to increase the dose to some extent, but not that often. Now, the typical effective dose of chlorpromazine, the one that they have there, in my experience, is a little bit on the low side, I have to say. But by the books, 75 to 300. We often go higher than 300 if we use it at all. The advantage of haloperidol is that you can give it IM in the emergency room as well. So that is more incisive and maybe useful. Now, haldol has more extrapyramidal side effects than chlorpromazine because chlorpromazine has anticholinergic effects packaged into it already, which makes it a low potency. The common side effects of extrapyramidal are, as you know, it's like a pseudo-Parkinsonism, so muscle rigidity, tremor, you can get an acute dystonic reaction. So they're mainly movement-related disorders. So the acute dystonia can be very painful, with the neck and the eyes going to one side, and that can be enough to make the person blacklist your medication from then on. So, you know, you want to avoid those. And we'll talk about that in a second. Less common side effect, well, just in passing, I often, for haloperidol, will give an anticholinergic at the beginning anyways, because the likelihood of having these acute movement disorders is highest in the first period of treatment, first week or two. Less common side effects, sedation and urinary hesitancy. Why? Because there's very little anticholinergic side effects here. Now, the side effects of chlorpromazine are more on the sedation side, urinary hesitancy because of the anticholinergic, and orthostatic hypotension, the adrenergic side effects. And less common are the extrapyramidal ones, just like we just mentioned. So it slows people down more. Now, EPS, extrapyramidal side effects, they're the most characteristic side effects, the most usual ones, and involuntary, repetitive, aimless movements. And they can create contractions, contorted positions, pain, especially the acute dystonia. Anticholinergics are the usual management. So you might first try to reduce the dose of the antipsychotic medication, as long as you're not going under a therapeutic level, but you may also consider anticholinergics. As I mentioned, I will sometimes use them early in the case of a high potency medication like haldol, even this for a short time, like a few weeks or a month. Now, obviously, anticholinergics can cause cognitive side effects on memory, for example. So if they're not without problems themselves. Which are the usual? I think that on the list of essential medications, you have biparidin and trihexyphenidyl. Here, the biparidin, you can start at 1 milligram twice a day, but you can increase that up to 12 milligrams total. Same with the trihexyphenidyl. We ourselves use procyclidine here very often, and that can be given from 5 milligrams to 20 milligrams a day. Now, when would you not use an antipsychotic medication? Well, certain comorbid serious medical conditions need to be treated as opposed to starting antipsychotic. You want to know if treating the medical condition will be enough. Now, if there are contraindications, as you will see on page 21 of your MHGAP, then those are other reasons. Now, if also there is fever, delirium, muscle rigidity after starting the medication, those are very bad signs of what we call neuroleptic malignant syndrome, a very dangerous syndrome that you may know about. I hope that you do, and if you don't, you'll need to read about it and know more about it. Talk about it with your tutors. It's a medical emergency that needs to be treated within the emergency room. It says here refer to a specialist, but really, before referring to a specialist, if you have someone who's developing these symptoms, you want to rule out neuroleptic malignant syndrome within your medical services and treat the syndrome until it's controlled. And after that, you want to refer the person to a specialist to get their input on which medications can be used without causing as much danger. I hope you got that. It's a little different from what it says on the slide, but NMS, very important medical emergency. Sorry, I don't know if I mentioned, but there is a second video that I would like you to look at here, and you have it also on the virtual campus. It's going to give you a link to a video on YouTube, and that is about the management of psychotic disorders. It's a continuation of the previous video. Well worth a watch. Very well acted, very well done, very natural. So please look at it, and also think of your own patients who fit some of these patterns and see how you would deal with them given this new information. Okay, link with other services and supports. What's available to you? You may need other sectors like supportive employment, housing when someone has a long-term psychotic disorder. If it's short-term, that may not actually be an issue. Rather, your role may be to help them re-engage into their usual work, write the letters that are needed to help them manage whatever preconceived ideas people at their workplace have against them. So help them re-engage. You may have, and you should have, a very active normalizing role in this. What this slide seems to be referring to is more long-term schizophrenia-like psychosis, where people may have longer-term difficulties with work, employment, housing, etc. Is there specialized care available to you, and is it something that you want to access for this patient that you have in front of you with psychosis? It will depend on how they respond, on what their history is, and how well they recover between episodes. Are there other help services? Because often people with psychosis, if they have problems financially, for example, or they break in their families, there are often other social determinants of health that come into the gyre. For example, they may not have enough money to buy good food. They may have health difficulties because they consume more drugs. There's a whole slew of complications of psychosis that help explain why people with mental health disorders have 20 years shorter life expectancy than the general population. This is where you want to help people avoid that plight. Okay, follow up. So you want early on to follow someone as frequently as you can. It helps you establish a therapeutic relationship. It helps you gain confidence of the patient. It helps you avoid and observe rather and avoid risk behavior. It helps you make decisions about what the next step is in terms of adjusting your interventions. So one of our most important tools, and I always say this in psychiatry, is follow-up. It sounds ridiculous, but it isn't at all. We have people who may not understand what's going on with them. Your presence and your understanding is more needed than in most other medical conditions. Once the symptoms respond, you can start seeing them less often, but you will have to adjust this depending on what you see as being clinically indicated. Most people will recover, and if they don't, then you have to really wonder whether you've optimized doses, whether you're getting too many side effects, or if there's an underlying other condition that hasn't been treated. And if you're out of your depth there, get help. When available, a consult with a mental health specialist is going to be useful. At each follow-up, you're reassessing symptoms. Some people like using short scales. Even if you don't have a scale, you can, in your first note, you will have written the main symptoms, and you just follow them over time. You go back to your first note and ask them if they still have A, B, C, or D. And you want to monitor side effects and make sure that they're not so severe that they may be contributing to the person's poor functioning. And then you want to go over adherence, not only to medication, but to treatments in general. I don't see medication as the only, nor even sometimes the most important part of treatment. Many of the psychosocial interventions may bear even more importance to the person, and certainly your intervening at those levels will increase the strength of your therapeutic relationship. An example is that of work. You're being an patient advocate at that level will ensure your patients, well, not ensure, but certainly optimize their ability to trust you. Non-adherence to medications, at least, certainly to follow-up is common, so you want to use the family and carers. You want to manage and care confluent medical conditions and involve psychosocial support. Keep using psychoeducation on an ongoing basis. When the person gains some insight, remember that that may be the most difficult moment, because they have to face the fact that they lost contact with reality and wonder what they're going to do with that. How do they integrate that into their view of themselves? It's an important confrontation to their sense of identity, and your input, or you're connecting them to people who can help them with that, is really very important. Okay, page 22 is monitoring antipsychotic medication. If the response is inadequate after 4 to 6 weeks, that's a long time, but still, as mentioned before, review diagnosis. Look for comorbid conditions. Rule out other things that are other insults that are bringing the psychosis on or maintaining it. We want to ensure that there's good treatment adherence. We sometimes, in cases like that, if we feel that there's poor adherence, work hard on longer acting medications. You can increase the medication along the guidelines on page 21, but make sure that you're not causing more side effects, some of which may bring a worsening of the condition. I'm going to mention here, and I'm not, it's just too much information. When you discontinue medications, for a first episode, you maintain meds at the lowest therapeutic dose for 12 months. For other people with longer-term conditions, you want to wait several years, have patients on your side when they have insights, working with you on checking for symptoms and checking for any early signs of relapse if you slowly taper the medications. It's a good idea to consult someone on that question. When do you refer? Here in this base course, we'll learn about first-line treatment. We'll learn about very few drugs, a few side effects. So if it's beyond that, you may want to refer. If response to medications and going through the guidelines mentioned before about poor response doesn't work, then you're going to want to refer to a specialist. If more advanced management is required, you may want to refer. Okay, so key messages. This is a mental disorder, psychosis is. And the abnormalities in thought, emotions, and behavior are marked, very disruptive, and confronting to the person's very sense of identity. Psychosis, though, can be managed by non-specialists like many of you are. Always make sure that you protect the person's dignity, you respect them, you prevent human rights abuses from coming into the picture, as they will only worsen things when it's due to a medical condition like a mental health problem. Always rule out other medical conditions that may be the cause or may become concurrent. Very important that you don't ascribe any new symptom to the psychosis. Please do this. We see in the emergency room all the time physicians who assume that a presentation might be due to the person's having a psychiatric disorder, and under investigating complaints that deserve investigation, just like they would in anyone else visiting the emergency room. You want to provide the psychosocial and pharmacological interventions that are relevant. Remember and remind people that most people will recover, and know how to follow up and when to refer. That's it for today, folks. We've done our hour. I encourage you, as mentioned, to look at the videos and to discuss some of the questions that we mentioned with your tutors, and I hope that this has been useful to you. Looking forward to getting your feedback. And I'm sorry for not having been able to give you this lecture in the timely manner that we had initially planned. That's it for today. Goodbye.